alkaline. So you're thinking, okay, now right now I don't see the patient, but if the CO2 is normally 35 to 45, now it's 25, what's their breathing rate going to be like? It's going to be fast, it's going to be deep. They're going to be blowing off a lot of CO2. That's the bottom end of normal. Okay, give them a little bit of extra oxygen, take care of that PO2. Not a big deal. And then the bicarb, this thing's pretty low, right? And this is acid. So, first of all, let's just name this thing. We're going to say since the pH is acid, it's going to be acidosis. Okay, and what are we going to blame it on? We can't blame it on that guy because he's alkalinic. So we're going to go over here to this guy. That's the bicarb, so it's metabolic. And are we compensating for this? We're trying to. We would actually call that partially compensated because this is trying to help out, but it's not. You know, we haven't brought this back to normal yet. So we're just going to call it compensating, but it's not totally there yet. So this patient, what kind of patient would this be? What kind of patient has an excessive amount of hydrogen ions floating around their body? You got multiple different ones. You have a septic patient that's really starting to swirl the drain. You also could have a renal patient that definitely needs some dialysis in this case. Now, what happens and how does this bicarb get turned around now? So if we go into this little equation, and it's about the only equation that I know, but I think it's pretty cool. Now this goes to carbonic acid here in the middle. We're going to skip that step because this equation is going to show you what happens to bicarb in this situation. So we put in this situation where we have a lot of H plus floating around, if we give them some bicarb to try to fix this problem, what it's actually going to do is going to convert it out into CO2 and water. Well, what do we have to do with this CO2? That's going to increase this level, right? So that's going to kind of screw us up a little bit with that. So we don't really like that. So you got to make sure if you get bicarb in these situations that your patient is ventilating really well. Mainly, if you're going to give a lot of bicarb, they probably need to have a BiPAP on at least, or possibly be intubated. But one thing you can do is, of course, you can give bicarb. It's kind of a quick fix. I mean, it's not going to last real long. You got to find the reason for this excess of hydrogen ions. So you're going to look into sepsis, you're going to look into renal failure, and multiple different things from there. You can go into anion gap to see the source of it. We're not going to go into that today, since we're just kind of going through the basics. So in this case, we have compensated metabolic acidosis. Am I going to call the doctor with this? Heck yeah. Because what's going on right now, we're in an acidotic state, and this patient is compromised right now. Are they able to keep up? No, they'll probably have a respiratory rate of about 35 right now, 25, 35, and they're not keeping up. What's going to happen after an excessive amount of time? They're going to slow down, and they're going to go to 20. So this goes up a little bit higher, and it goes back to, let's say, 35. This causes the pH to drop lower and lower and lower. So this would definitely be an opportunity that you would call the physician on this one. So you're probably going to think they're going to intubate this patient, and you're going to say, you know, a respiratory therapist may come over and say, hey, what are we intubating the patient? You know, they always say that, you know. They're trying to fight like everything. What are we doing this? What are we doing that? Hey, there's a reason to intubate this patient because with this, although we are in a metabolic acidosis, and that's what they'll tell you, this is all metabolic. Yeah, it is, but they're going to wear out. And that's the reason we're going to intubate them, because we don't want to let them go and wear out and then have this CO2 start to rise. That's actually what the crash is. If you're talking about somebody crashing, it's when they're keeping up somewhat and then all of a sudden they can't anymore. Or they go into a anaerobic respiration, which is what? Breathing without the oxygen. So as they're breathing quickly, let's say this thing starts to go down. This ends up being 55. Okay, then they start doing some anaerobic. Well, what comes out of anaerobic respiration? Hydrogen ions to cause this to go lower. That's the crash. So we're going to intubate them right now to stabilize this thing. We can take care of this pretty easily. Okay? We may put them on a high rate on the ventilator, but we're going to stabilize this while we take some time to try to fix this issue here. Also, diabetic ketoacidosis. I kind of left that one out. DKA. Very similar. Now, that's a little bit easier to fix, right? Put them on the insulin drip and draw blood gases, every 6 hours or so if you want to see where they're at as far as the pH level. We can also draw a venous blood gas. Well, venous blood gases, you're just looking at the venous pH, which is just usually just about less than 0.5 of a point different than arterial. So that's a little bit less invasive. You don't have to stick them in the artery every few hours. So you could check their pH in that instance. So this is something you definitely have to call a physician on. Now, let me go into one that kind of looks funky, but is a normal one. Okay, so we're going to look at this blood gas. We're going to say, okay, let's go through it. This is normal. This is like super high, right? Super acidic. And this is like really alkalinic. And this is, on the low end of normal. It's a little bit low. Well, what the heck do we got going on here? Let's see. We've got, well, we don't really know what to call it because we don't have anything written here. If you don't know what to call it, in school, this is what we used to do, 7.40. What side are you on of that? We're on the acidic side. We're going to put acid there. And so I'm going to call this an acid, so I'm going to blame it on respiratory because that's there. And then are we compensating? Yeah, we're compensating. And actually, we're fully compensating because this is normal, so everything's working out for us. So I come over and hand the blood gas to you, and it's going to show this 80 with a red letter next to it saying H, and maybe it'll have 2 H's next to it, and this is going to have 2 H's next to this and say high, and it's going to be lit up red, and you're going to think, oh my gosh, I got to call a physician right now. Not necessarily, because your pH is within the normal limits. Now, what kind of patient is this? This is your chronic respiratory failure. Well, what the heck, that's over a long period of time. Chronic respiratory failure is somebody with emphysema related to their COPD. Of course, COPD has multiple branches that come off of it. All of them are obstructive disorders, and they cause somebody to retain CO2. So, in this case, we're going to say, all right, you probably look at this patient. They look like they do every other day. Maybe they're having a little bit of trouble breathing because they need a breathing treatment, but maybe they're not in any distress because this is a normal blood gas. Well, how in the heck does that happen? Well, they've worked on this their whole lives, smoking and whatnot. So this slowly increasing over time, but it's slow enough that this can keep up and keep this normal. So this is what their normal range is. So the big key is pH normal. There really wouldn't be a reason to call the physician because of this blood gas. Make sure you pay close attention to your pH. That's going to tell you about how well you're balanced. Either you're in balance or out of balance. I would say if your pH is out of normal range, it's something to probably need to contact your physician over. Let's go into one more. 7.25. 70, let's say 80, and let's say 30. So you're saying, okay, what's the deal here? So let's look at this. We're going to go, this is acid, we know that. So we're going to call the doctor on that. We'll check mark that one off. This is acid, this is normal, and this is alkalinic. So we're going to say this is an acidosis. It's going to be a respiratory thing because I know this one right here. And we're compensated, but we're going to call this partially because this is out of whack. So, do I call a physician with this one? Yeah, we already said we do. What kind of patient is this? This is a COPD patient that is having an acute exacerbation. So this is going to come back and say